and go on to our next speaker to try to get back on time, Dr. Christopher Rhodes. His research focuses on diabetes, obesity, and metabolic diseases and associated complications. His PhD is from the University of London, and he has held faculty positions at the Harvard Medical School, University of Texas Southwestern Medical School, University of Washington, and the University of Chicago, and is currently the chief scientist for cardiovascular, renal, and metabolic diseases at AstraZeneca, and professor emeritus at the University of Chicago. The title of his talk is Approach to Precision Medicine for Common Type 2 Diabetes.
Well, thank you very much for that introduction. And I would also like to thank John Nolan and the organizers of this really outstanding meeting, and especially for the challenging title that they gave me. I think at first, this is my conflict of interest. As noted, I am an employee of AstraZeneca and I hold stock in the company. But I'd also like to start off with a challenging statement from Henri Matisse. Precision is not reality. And you'll see perhaps this will go forward in my presentation when I want to emphasize the practicalities of introducing precision medicine, considering all these marvelous advances, particularly in genomics and omics that we've heard about previously, to implement now for common type 2 diabetes, which we've heard is an umbrella of different subgroups of diseases. So the Precision Medicine Initiative, as run by the NIH, mentions genes, but it also mentions environment and lifestyle. And I'd like you to introduce to two family members of mine, passed away, my Aunt Irene and Auntie Joyce, identical twins, similar genetics, but lived into their 90s, but succumbed to quite different diseases. My Auntie Joyce succumbed to osteoporosis and respiratory issues. And my Auntie Irene succumbed to complications from Alzheimer's. So this emphasized that it's not all genetics, it's environment and lifestyle as well. And I think we also have to remember, by these, it's nicely outlined by these T-shirts here, that it is ever changing on a daily basis. So how might we implicate precision medicine for common type 2 diabetes? As we've heard, for diagnosis, prediction perhaps, prevention, certainly prevention of moving to the difficult complications of type 2 diabetes. We've heard we can use it for patient segmentation, also determining treatment options and disease monitoring as the disease either gets better or worse depending on the treatment. So how can this practically be implemented? And with my tongue somewhat firmly placed in my cheek, we came up with the CRIS criteria to consider practical implementation of precision medicine for type 2 diabetes. It has to be cost effective. That is, it's got to be relatively cheap for it to be widely used. Of course, it's got to be reliable, accurate, and measures the same thing reliably every time. It has to be robust. It also has to be intuitive, easy to use. If it's complicated to use, people won't use it. It has to be easy. And finally, of course, it has to be sensitive. It's got to measure the thing that it's measuring in the appropriate physiological range. So I think we are already quite precise with glucose measuring, which has run for the last 80 years or so. And this is the evolution of glucose monitoring, which is now done continuously monitoring. We can also, sorry, I should go back. We should also remember that even HbA1c is also conveniently measured in this day and age. And I love the way continuous glucose monitoring is so precise. We can do it preclinically in rat models of diabetes, as you can see here on the left, an obese rat model given a long-acting insulin, and you can see how well the glucose is coming down compared to the controls. And we use it regularly in clinical trials. Here, looking at a glucagon GLP-1 dual peptide action in having great effects on reducing the variance in glucose on a minute-to-minute basis. So I think we're outstanding with precisely measuring glucose in type 2 diabetes, and in many ways we're the envy of other diseases in being able to do this. But as I'll come to later, it's not all about glucose, as we've heard from previous presenters both today and yesterday as well. So can we predict type 2 diabetes? And Miriam nicely went over this briefly, and I think we can. But I think what we have to do is that there are now over 400 genes, some believe over 700 genes now associated with susceptibility to common type 2 diabetes. The question becomes, although this has been a marvelous insight into getting new information about the pathogenesis of common type 2 diabetes, can these genetic signatures be practically implemented so that we might be able to predict common type 2 diabetes? Each of these genes give a little bit of give a little bit of that diabetes susceptibility, and many of these genes can contribute to a bigger contribution to that disease susceptibility. But with that small contribution of each gene, how do we put a signature together? And how do we put this to practically implement it that meets the CRIS criteria, particularly in terms of cost and ease of use, so that we can better predict the disease? I'll point out, as we'll probably hear later, the genetic susceptibility, which is much stronger in type 1-2 diabetes with the DR3, DR4 HLA locus. We've known it for 30 years plus, but how has it been practically implicated to predict type 1 diabetes? This is difficult. One of the main reasons is, how do we treat disease susceptibility in so-called normal people who have yet to get the onset of that disease? It's an important question that I think we need to think about. And here again, we've heard probably for the third or fourth time this morning, is this marvelous landmark work from Leaf Group and colleagues that started it all off in segmenting type 2 diabetes as subtypes. We've heard this has the potential for a vision to better characterize common type 2 diabetes into these segments and other segments as well. But I think, as we've already heard, it does still need substantiation, even though it is being confirmed in diverse populations around the world. It still needs substantiation to lock it in, so to speak, so we really know what this segmentation is about. The variability, as Miriam and Dr. Mohan have both pointed out this morning, is that patients can jump with these categories. Their disease progresses or their age progresses. And that, again, implements lifestyle and environmental changes as well as their genetic basis. And again, how can we usefully practically implement this really excellent information to meet the CRIS criteria so it can be part of predicting segmentation of type 2 diabetes and bettering the treatment options for patients? It's already actually been used in the pharmaceutical industry in clinical design, not only for pointing out new targets for type 2 diabetes therapy, but also designing the trials not only with a view to the diabetes, but in view to treating those complications that might occur as well, and better concentrating a subset of type 2 diabetes that might actually be more responsive to a novel type 2 diabetes therapeutic. So I want to touch on precision diagnosis for common type 2 diabetes. And here I want to take the mandate that oncology has. The earlier the detection in oncology, the more timely the treatment can be, and then a better prognosis can be had by those patients. And in oncology, they're using some fantastic novel technology. For example, circulating tumor DNA is predicting cancers earlier. Fantastic advances in using artificial intelligence and machine learning for image analysis is picking out tumors that we wouldn't be able to see, again, giving a much earlier detection of disease in oncology. But for common type 2 diabetes, if we had early detection, we could implement timely treatment earlier and hopefully prevent those dangerous complications that kill us with type 2 diabetes coming. I think it's something that we should really be focusing on and trying to proceed as a community. One of the issues is that we're rather glucose-centric in type 2 diabetes. And as we all know, that this is the current diagnosis for diabetes based on glucose and HbA1c, very glucose-centric, together with implementing other considerations, which Dr. Mohan really pointed out nicely this morning: BMI, age, family history, etc. Pre-diabetes at the moment is also a little bit glucose-centric and highly variable within that 100 to 125 milligrams per deciliter range. And also, one would have to consider the other considerations of BMI, age, and family history with pre-diabetes diagnosis. But I think we have to remember the historical decisions made for these cutoffs for glucose to define diabetes. And originally, back in the 1960s, these were based on the increased prevalence of retinopathy, which was above that 126 7 millimoles per liter cutoff for diabetes diagnosis. So in other words, the complications had already set in with this current glucose-centric diagnosis. And the predominant focus on glucose also inhibits a little bit with selecting treatment options as we move forward. So I want to come back to the concept that type 2 diabetes is not only about glucose, it's all about insulin insufficiency relative to the metabolic demand and degree of insulin resistance presence, as is pointed out with the segmentation of type 2 diabetes in many ways. And I want to highlight the disposition index here, where increasing insulin resistance going from right to left here along the bottom is relative to insulin secretory function. So normal folks, the more insulin resistant they get, their beta cells will compensate to be able to keep them on this curve. But when beta cell secretory function begins to decline or get dysfunctional, in the light of the ever-increasing insulin resistance, probably going hand in hand a lot of the time with obesity, you fall off this normal curve into a glucose-impaired state and eventually a type 2 diabetes state. And this, of course, is the nice work of Richard Bergman and others who started this disposition index. I also want to point out that the beta cell is not a static functioning cell itself. It is also highly adaptive to monitoring the metabolic circumstances. So here, in a severe form of mouse preclinical obese type 2 diabetes, if we look at a normal mouse, it has very nice insulin secretory granule, a storage pool of insulin ready to give on demand postprandially whenever we want. But in obese type 2 diabetes, the beta cell is trying enormously hard to deliver as much insulin it possibly can into the circulation to compensate for that increase in metabolic homeostasis and the demand of insulin resistance. But if we alleviate the insulin resistance, the endogenous beta cells have the opportunity to rest and recover their endogenous insulin secretory stores and gain back their insulin secretory function. And this can be done pharmaceutically with insulin sensitizers and certain agents that will reduce the insulin resistance, but also in humans as well. And this is nicely illustrated with the examples of very low calorie diets, therapy, and also bariatric surgery. So this adaptive beta cell function enables us to move along up and down this normal curve. And in some circumstances enables us to move from these red and yellow lines back to a normal state to have diabetes recovery, of which that low calorie diet and bariatric surgery are very good examples. One thing that really got me considering was going back to a moment in time that happened in my family a few years ago. And let me introduce you to my two brothers, another genetic component. One of my brother here went for an annual checkup earlier on because he was feeling a little bit too tired. And when he had his annual checkup, they did a rather thorough checkup on him. He had a normal fasting glucose, but he had a fasting insulin, which was 5 times higher than normal. He talked to me about it as a so-called diabetes expert, but it actually made me go and get myself tested as well at the same time. And I had a fasting glucose that was relatively normal and an insulin that was holding myself normal. My other brother, went to have his annual checkup at more or less the same time. And he had what is more commonly done with people in the UK and the US, at least from around the world, is that they have their fasting glucose tested, but not their fasting insulin. And so one might consider this high insulin, but normal glucose is potentially a pre-diabetic state. And measuring insulin is not routinely done in checkups. But perhaps we should be considering a more common measurement of fasting insulin when we look at pre-diabetes and diagnosis of insulin itself. By the way, my brother here, with a modification of his diet and exercise, which was basically taking the dog out for a walk more often and not going to the pub so frequently, really recovered his diabetic state and came back to a normal fasting insulin about a year later, a normal glucose, and is now doing very well. So it shows you that this can be a reversible state. So this made me think, and others around me think about a more precise diagnosis for common diabetes. Might we consider an insulinometer? As I said previously, insulin is not routinely measured as it doesn't really fit that CRIS criteria. It's not necessarily cheap and it's not convenient. You have to send a blood sample out to a laboratory to get it done, and it takes a day or two to get back and get that result back to the patient. But if he had a more convenient way of measuring this, perhaps we can envision an insulinometer. We take a blood sample, get plasma or serum from it, put that spot of plasma or serum on a microfluidics card, put it in a reader, and get a measure of what the level of a fasting insulin might be. And we put that together with a glucometer's reading of that fasting insulin, a fasting glucose measure, and we get fasting insulin, fasting glucose, and from that, we can calculate the HOMA IR or HOMA beta and get an idea not only of the glucose homeostasis, but the relationship between insulin resistance and beta cell function in the patients. And if this could be implemented, it could all be done in a physician's office and get the result within 15 minutes. And such an insulin-based diagnosis, together with the glucose-centric diagnosis, we might better decide on a better treatment. If the glucose is high and the insulin is low, perhaps a more insulin-based therapeutic might be appropriate. But if the insulin is high together with a high glucose, perhaps a therapeutic that addresses insulin sensitivity and or bringing down the glucose concentration in an insulin independent manner might be considered. The technology for this actually exists. So when we consider the other pandemic currently ongoing at the moment in COVID-19, the home testing kits use this sort of technology to be able to get a measure of COVID infection, which measures a protein in the coat of the viral particle relatively quickly. And if this was measuring insulin except for that coat protein, perhaps we might have a better way of diagnosing and consequently a better idea of how to treat diabetes as a consequence, if this could be practically implemented, meeting the CRIS criteria. So in summary, we are entering and probably very much in an exciting era of precision medicine, especially for genomics. But I think it's difficult to take that to an individual patient approach, given the practicalities of considering how to implement that on an easy basis. Environment and lifestyle variables will always be confounding, as we know. Predicting common type 2 diabetes with genomic susceptibility will be challenging, but I want to point out that, that with time, it could well be there. Segmenting common type 2 diabetes is intriguing, it needs substantiating, but again, we must consider the practical approaches of how we go about bringing that in. Precision medicine for common type 2 diabetes is not all about glucose, and I would strongly advocate that we need to consider measuring fasting insulin too, so we can get a better idea of the relationship between insulin resistance and beta cell demand. So I think this could be improved upon. And if my take-home message, as we consider precision medicine, we need to consider the practicalities of implementing this so that our patients with type 2 diabetes can be better treated and better diagnosed. So I come back to Henri Matisse, and that precision is not reality, and we must consider how we practically implement it to get that precision. So I'd like to acknowledge a couple of my colleagues, Anna at AstraZeneca, Anna Reznichenko, Joe Grinzi, and Rob Hastings for helping put together some thoughts for this presentation. And I'd like to thank you for your time in doing this. Thank you.
Thank you so much, Dr. Rhodes. That was a fantastic presentation. For time, we are going to hold on questions, but we do encourage the audience to continue submitting questions for the panel discussion at the end.